Now let's describe in detail the differences between type 1 and type 2 diabetes mellitus. To help you learn these concepts, we'll be using a table in your book, and we will work through this, so try to fill in the answers as we go along. Practicing active recall is, as you know, a great way to solidify concepts that you'll be tested on. Let's start with the primary deficit or underlying cause of the disease. For type 1, this is a true lack of insulin production secondary to autoimmune destruction of beta cells. Do you know what type of hypersensitivity reaction this is? It's type 4, as it is T cell mediated. How does this compare with type 2 diabetes? Well, this is due to insulin resistance, meaning that after a prolonged period of hyperglycemia on the scale of years, the cells no longer respond to the high levels of insulin being produced. Eventually, however, these patients may require injected insulin because of the progressive failure of beta cells. This is known as beta cell burnout. So, I mentioned that later in the disease course in type 2 diabetics, these patients will require insulin. But how about type 1 diabetics? Well, these patients always need insulin as part of their therapy because they have lost the capacity to make sufficient insulin. Type 2 diabetics can use oral medications that promote increased secretion of insulin as well as sensitize cells to the effects of insulin. Over time, however, most patients will also require insulin therapy. At what age do you expect type 1 diabetes to occur? Generally, we think of younger patients. But keep in mind that though type 2 diabetics are usually older, there is a rise in type 2 diabetes in children, which seems to parallel the rise of obesity seen in these children. Now, what is the best way to prevent this? I hope you're saying diet and exercise. So type 1 diabetes is not often associated with diabetes, whereas type 2 diabetes is. Now, true or false, type 1 diabetes is associated with genetic inheritance. Well, this is false. Type 1 diabetes has a weak genetic association, and when we do twin-to-twin studies, only 50% of the time will one twin with type 1 diabetes have a twin who also develops diabetes. This type of twin study allows you to determine the concordance rate, which is 50% in this case. Contrast this with type 2 diabetes, where 90% of identical twins both have diabetes. Unlike type 2 diabetes, type 1 diabetes does not have an association with HLA phenotypes. Do you know which one specifically? HLA-D3 and D4. And if you remember from immunology, HLA-DR is expressed on antigen-presenting cells and will bind to the T cell receptor on CD4, and as I mentioned earlier, type 1 diabetes is associated with a T cell mediated type 4 hypersensitivity reaction. Now that you know this, it is not so much memorization, rather, you have an understanding of the pathophysiology and can draw conclusions based on this. You can't memorize everything, but you can think through problems and work them out once you have a solid foundation of knowledge. Now let's briefly go over the clinical features associated with type 1 versus type 2 diabetes. For type 1, the patients have severe glucose intolerance, and this is because they are not making insulin at all. Thus, they have high insulin sensitivity. On the other hand, in type 2 diabetes, we have mild to moderate glucose intolerance and low insulin insensitivity. Remember, there is peripheral resistance in type 2 diabetes. We mentioned earlier that type 1 diabetics can present with ketoacidosis as a result of high levels of glucagon promoting lipolysis and relative starvation due to the inability of these cells to uptake glucose. Now with type 2 diabetes, we have low insulin sensitivity, but we rarely have ketoacidosis because despite the insensitivity to insulin, insulin can still have an inhibitory effect on glucagon production. More commonly, we see non-ketotic hyperosmolar coma as a result of hyperglycemia. What do you think happens to the beta cell number in the islets in each of these conditions? In type 1, they're decreased, and in type 2, they're variable. The same goes for insulin levels. They're decreased in type 1, and they're variable in type 2. The classic symptoms of polyuria, polydipsia, polyphagia, and weight loss are much more common with type 1 diabetes than with type 2. Now, if we were to section the pancreas and look at the cells under a microscope, what would we see? Well, remember, type 1 diabetes is related to an autoimmune process, so we see an inflammatory leukocyte infiltrate, and over time, the number of beta cells will decrease. Contrast this with type 2 diabetes. The features include amyloid deposition in the islet cells. Regarding islet histology, the issue in type 1 is leukocyte infiltration, whereas in type 2, we see amyloid deposition. The amyloid deposits, and specifically the toxic oligomeric forms that are thought to cause the destruction of beta cells, occur in the late stages of type 2 diabetes. A discussion on diabetes mellitus would not be complete without delving into the details of diabetic ketoacidosis or DKA. This is an incredibly important topic, both because of its major clinical significance and also because understanding this disorder requires integrating your knowledge of diabetes pathology with renal and pulmonary physiology. DKA is most commonly seen in type 1 diabetics. It is an insulin deficient state that occurs due to decreased supply, for example, underdosing or skipping insulin doses, or increased demands that are not being met, for example, from stress, illness, or infection, or even myocardial infarction. This results in severe dehydration. And of course, this dehydration comes from what? Correct, osmotic diuresis. Also, one will see increased ketone synthesis leading to ketoacidosis, and patients with DKA may not know that they are diabetic, and this can be their initial presentation, especially in type 1 diabetics. The typical presentation includes a history of polyuria, polydipsia, or increased thirst, and polyphagia, which implies increased appetite or weight loss, as we discussed earlier. They will also show signs and symptoms of dehydration, which include increased skin turgor, prolonged capillary refill, and orthostatic hypotension. Nausea and vomiting are also typical findings, in addition to generalized abdominal pain. You may notice a fruity breath odor, which is due to acetone, a ketone. Lastly, if the DKA is severe enough, the patient may present with delirium or coma. Laboratory findings include hyperglycemia, often with blood glucose levels greater than 450, but not in the 1,000 range like in HHNS. As you recall from our earlier discussion, when the body produces ketones, you have formation of beta-hydroxybutyrate, acetoacetate, and acetone. Do you remember which ketone is most often elevated? Beta-hydroxybutyrate. Now, do you remember from your acid-base studies what happens when you have elevated levels of ketones in the blood? Well, we get a metabolic acidosis, specifically one with an elevated anion gap. This is seen in the setting of diabetic ketoacidosis, which makes up the D in the Mud-Piles mnemonic. Another key point, whenever presented with a case of acidosis, you should calculate the anion gap. Remember, to calculate this, we take sodium and subtract from it the chloride and the bicarb. If the result is greater than 12, an elevated anion gap is present. Lastly, due to metabolic acidosis, you may see a rapid, deep breathing phenomenon known as Kussmaul respirations, which is the body's way of compensating for the metabolic acidosis by blowing off CO2. Two other common laboratory findings include leukocytosis, which may or may not represent an active infection, and hyperkalemia. Remember that insulin promotes the uptake of potassium into cell. So in the setting of DKA, what will the serum potassium levels be? Well, they'll be high. But keep in mind that the total body stores of potassium are low because of the large amounts of fluid loss from polyuria stimulates the production of aldosterone, which leads to potassium loss. So when you give insulin to treat this patient, they will also require potassium. There are many potential complications from this life-threatening condition. Patients may develop mucormycosis, which is frequently due to rhizopus infection, and often manifests as black necrotic nasal discharge, as discussed in the microbiology lectures. You can also have cerebral edema related to the osmolar shift, and cardiac arrhythmias, or heart failure. The mainstay of treatment in DKA is IV fluids, starting off with normal saline, insulin, and potassium. You'll learn in your clinical training more of the specifics for DKA management, and at a certain point, you will start adding glucose to the IV fluids. But for now, you just need to understand the basics of the treatment of DKA for step 1. Remember, DKA warrants admission to the ICU for frequent lab draws and monitoring for cardiac arrhythmias.